Hi everyone, I'm Ro'a and today we'll be talking about neuropsychiatric manifestations of stroke. Many patients who have had a stroke experience some neuropsychiatric events such as apathy, depression, anxiety, PTSD, irritability, pseudobulbar effect, impulsivity, mania, and even psychosis. This is a table that shows the occurrence of each of those manifestations in post-stroke patients. Post-stroke neuropsychiatric disorders can follow either an ischemic or a hemorrhagic stroke. Attempts to link specific psychiatric disorders with the type, mechanism, or location have not been clear. Post-stroke neuropsychiatric disorders do not only solely occur as an adjustment reaction to the disability or the awareness of one's mortality, but rather there is direct neurophysiological effect of a stroke that can cause depression and other disorders. While the definitive explanation for these disorders in stroke patients remain unknown, there are some theories that can include inflammation of the hypothalamic pituitary adrenal axis deregulation, serotonin-mediated effect on platelets and endothelial function, and/or excessive sympathetic tone. Some general treatment principles apply across different post-stroke neuropsychiatric disorders. Up to 25% of stroke patients will experience a second stroke in the next 5 years, and hence the patients need appropriate secondary stroke prophylaxis, such as antiplatelets agents and anticoagulation for ischemic stroke, control of hypertension, hyperlipidemia, and diabetes mellitus, assistance with smoking cessation, and regular exercise. If possible, psychiatrists should avoid prescribing medications that have adverse metabolic effects, such as atypical antipsychotics, or that can cause hypertension, such as CNS stimulants and SNRIs. It's very important to review with the patients and their families the warning signs of a stroke and the importance of immediately calling 998 if such symptoms arise, and hence the thrombolytic treatment can be administered appropriately. Patients with post-stroke neuropsychiatric disorders require ongoing evaluation of suicide risk, as up to 7% of patients with stroke subsequently die by suicide. That's a much higher rate than the general population, and the elevated suicide risk may persist up to 5 years after a stroke. Depression represents the most significant risk factor for post-stroke suicide, although patients with less severe strokes and younger patients also show increased risk. Post-stroke fatigue may constitute an independent risk factor for suicidal ideation. This topic is very wide to cover, but I will be talking in a little bit more detail about two things, the post-stroke depression and the post-stroke apathy, as those are things that we encounter a lot in rehabilitation. Post-stroke depression may take the form of a major depressive disorder or a minor depressive disorder. It's very important to differentiate the symptoms of PSD from the post-stroke apathy because they are similar. However, some patients can experience both. Post-stroke depression may persist for more than 1 year in up to half the patients, and the depression, if it does not manifest in the initial post-stroke period, it can develop anytime over the next year. In addition to causing personal suffering, post-stroke depression is associated with adverse outcomes such as increased mortality. Patients with PSD also recover more slowly from neurological deficits and have more disability and worse quality of life. PSD responds to treatment, and treatment can improve both the mood, overall health outcomes, such as degree of disability, independent functioning, and mortality. Moreover, SSRIs, which are selective serotonin reuptake inhibitors, given to patients following stroke may actually prevent the development of depression, improve motor and cognitive outcomes, and reduce mortality. SNRI, mirtazapine, stimulants, repetitive transcranial magnetic stimulation, and electroconvulsive therapy may also known to improve PSD. However, the evidence based for SSRIs, which are selective serotonin reuptake inhibitors, and TCAs, which are tricyclic antidepressants, remains far more robust. Patients who receive antidepressants for PSD may benefit from continuing these medications for at least 2 years, since earlier discontinuation can cause worsening of the symptoms and relapses. SSRIs are probably represent the best first-line choice for the pharmaceutical treatment for PSD because persons with stroke experience more vulnerability to adverse cognitive effects from anticholinergic medications such as tricyclic antidepressants. SSRIs might also be beneficial for post-stroke motor deficits, And an increased risk of hemorrhagic stroke has actually been associated with the general population who are taking SSRIs. And hence, it's important to evaluate the risks and the benefit of the use of SSRIs for depression following a hemorrhagic stroke, and should be considered particularly when the patients take other medications that are known to cause intercerebral hemorrhages. Psychotherapy interventions aimed at optimizing the patient's family function, behavioral activation, and problem-solving strategies may improve PSD. Behavior therapy may also be effective for depression in patients with aphasia. Regular exercise also decreases post-stroke related depression. Now we'll get to talk about the post-stroke apathy. So in post-stroke apathy, it can manifest as lack of motivation, impairment of goal-directed activity, loss of initiative, decreased interest, and/or emotional blunting. Apathy may begin in the acute post-stroke period or develop in the chronic phase. Patients with post-stroke apathy show more disability and impairment of cognition than patients without apathy and have worse health-related quality of life. Now, this is just a table that differentiates between the PSD and the post-stroke apathy. So in PSD, there is anhedonia, which is loss of interest, activity, and even when others try to encourage them, they're not really interested. Patients describe their mood as low, sad, or down. There is frequent tearfulness, and the patient is usually very distressed about their symptoms. As when it comes to apathy, usually the patient is just a little bit indifferent. So there is decrease of initiative in undertaking activities. However, they can be motivated by their surroundings. The patient denies low mood or sadness. The mood is generally unreactive, and the family is usually more concerned about the symptoms of the patient rather than the patients themselves. Apathy frequently causes more distress to the patient's families than to the patients. Although the family often reports that the patient is depressed, the patient denies having low mood or true anhedonia. However, the apathy and depression can coexist together, and some patients can have them together. One study found that prophylactic post-stroke treatment with SSRI or problem-solving therapy can reduce the incidence of apathy. Thank you so much. I will leave the references in the next slides.